hurricanes precluded me from traveling to Kansas City. So, next slide, please. These are my closes. And the first slide is pretty important, as it outlines what I want to say in terms of anti-arrhythmic. So this slide was adopted from the ACC and the AHA from the 2010 guidelines. And you can see that the patients with atrial fibrillation were divided into 4 categories based on safety considerations of the currently available anti-arrhythmic agents. So on the left slide are patients with minimal heart disease. Next category are patients with or without controlled LVA. The third category are patients with atrial fibrillation who have current disease. And the fourth category are patients who have heart failure. So you can see that flecainide and propranolol are only indicated in patients with minimal heart disease, whereas sotalol is indicated for patients with coronary disease or with minimal heart disease. And that amiodarone is indicated for all 4 classes, and stenolide is indicated for all patients except those with LVA. Now, the addition to this guideline has been dronedarone, which is indicated for patients with minimal heart disease, substantial LVA, coronary disease, and in the youth, trial is not for patients who have heart failure, but in the European community, dronedarone is indicated for class 1 and 2 heart failure, but not class 3 or 4. And of course, in patients that have failed anti-arrhythmic agents, catheter ablation is indicated. One point is that based on recent data, dronedarone may be used in patients that have paroxysmal atrial fibrillation. And I love emotion. Now, next, what I'm going to focus on this slide are emerging terms. So butyrone is an amiodarone type with similar electrophysiologic effects as amiodarone, and has a profile that has a rapid absorption, rapid onset of action, and is cleared from the body within 48 hours. It is currently being evaluated in a phase 2B trial, which is in PrEP. The next slide covers other mechanisms for the development of anti-arrhythmic agents. We don't have time to go into these in any detail, but these agents focus on the atria rather than in the ventricle to maintain sinus rhythm. Metachelate is an agent that is under active evaluation, both in an intravenous formulation and an oral formulation. It has unique properties, but most of the promise, next slide, then it is also available, as I pointed out, orally, but these trials are not going as well as the intravenous trial. And the next slide covers Ranolazine. Ranolazine, as you know, was developed as an anti-Antiarrhythmic agent, but it was found during part of its clinical evaluation to be a promising agent for rhythm control in atrial fibrillation, and is currently under active evaluation for this indication. Next slide. Now, the Andrometer trial involved dronedarone, and was important in that the patient population was predominantly a heart failure population, and this trial, which was published in the New England Journal in 2008, showed that patients who were randomized to dronedarone in this heart failure population had higher mortality rates than patients that were randomized to placebo. And therefore, when this drug was evaluated definitively in the Athena trial, patients with class 3 and 4 and some patients with class 2 were excluded from the Athena trial. And the guidelines caution us in using this drug in the U.S. with any form of heart failure, and in Europe with class 3 or 4 on the basis of the Andrometer trial. Next slide is really concluding remarks concerning anti-arrhythmic agents. And there are a number of points that I'd like to emphasize. Atrial fibrillation increases the risk of death and severe vascular events. That's been known for a while. And until now, anti-arrhythmic agents have only been evaluated with respect to their ability to suppress the arrhythmia, atrial fibrillation, and not to determine the effect on clinical outcomes. So the first agent to be evaluated on the basis of clinical outcome was dronedarone, and that's in the Athena trial. So in the Athena trial, dronedarone was shown to decrease cardiovascular hospitalization, cardiovascular mortality, arrhythmic death, and in a post-hoc analysis, stroke. And very recently, not published, was data that resulted in the early termination of the PALACE trial, which is a trial that involved patients with chronic atrial fibrillation who were randomized to dronedarone. There was a higher incidence of death in these patients, and that was the basis for my recommendation to only use dronedarone in patients with intermittent atrial fibrillation. And among the novel agents, Dabigatran and Ranolazine show promise. Now, to next slide, please. The next slide outlines the emerging options for stroke prevention in atrial fibrillation. The bottom line here is that in the future, warfarin is likely to be used less commonly, and antiplatelet agents also less commonly, with the availability of novel anti-thrombotic agents. Also, what this slide is designed to show you is that there is a hierarchy of steps with respect to preventative measures related to stroke reduction in atrial fibrillation. The worst approach is not to protect the patient at all. Aspirin, as I will show you in a minute, is effective in reducing stroke in patients with atrial fibrillation, but is not as effective as aspirin and clopidogrel. And aspirin and clopidogrel, when compared to warfarin or a novel anti-thrombotic I will outline the results of trials that have evaluated Dabigatran, which is the only approved anti-thrombotic agent. It's a direct thrombin inhibitor and was evaluated in the RELY trial. I will also provide you the new data on Apixaban in its phase 3 evaluation, as well as data related to Rivaroxaban, which was published in the last 2 weeks in the New England Journal, the Rocket trial. Next slide shows the effect of aspirin versus placebo in patients with atrial fibrillation, which in aggregate reduces stroke by 26%. The only trial that showed a statistically significant reduction was the STAT1 trial. Next slide. The ACTIVE program compared clopidogrel and aspirin versus aspirin, and clopidogrel and aspirin versus oral anticoagulation. So clopidogrel and aspirin was more effective than aspirin alone, and clopidogrel and aspirin was less effective than oral anticoagulation with Warfarin. But what was surprising in the ACTIVE trial was that the major bleeding complications attributable to clopidogrel and aspirin when used chronically were similar to those seen with oral anticoagulation with Warfarin. So here is the data. This is the data from the ACTIVE trial showing an overwhelming benefit of oral anticoagulation in comparison to clopidogrel and aspirin. This is the data from the same trial that shows that the major bleeding rate attributable to oral anticoagulation with Warfarin and clopidogrel and aspirin were identical. Now, what about Warfarin? Warfarin has been shown in 5 clinical trials to be superior to placebo in patients with atrial fibrillation with respect to stroke reduction. And the overall benefit is approximately 70%. And in some trials, the benefit is over 80%, for instance, the backup trial. So there is no doubt that Warfarin is a highly effective preventative measure when used in patients with atrial fibrillation. Next slide. However, we recognize that Warfarin is a difficult drug to use, and over the last 20 years, there's been a massive effort to develop an alternative to Warfarin. The first agent to be approved by the FDA was the direct thrombin inhibitor, Dabigatran. Dabigatran is an agent that is a prodrug that is given by mouth and converted by kchrs2011 into the active form of Dabigatran. There is no p450 metabolism and therefore less opportunity for drug-drug interactions as opposed to what we see with Warfarin. When given by mouth, the patients are therapeutically anticoagulated within 2 hours. The drug is given twice a day, and because of its highly predictable pharmacokinetics, no monitoring is required. The only drug that is contraindicated for use with Dabigatran is Warfarin, which induces P-glycoprotein and results in subtherapeutic levels of the drug. And the final point, which is obviously very important, is that the drug is eliminated predominantly by the kidney, 80%. So the FDA approved the dose of 150 milligrams BID for a creatinine clearance of greater than 30, and 75 milligrams BID for a creatinine clearance in 15 and 30. Next slide. Apixaban is a factor Xa inhibitor that has been evaluated in 2 large phase 3 trials. It is different from Dabigatran in that it's only 25% renally excreted, and no monitoring is required with Apixaban. Dabigatran was evaluated several years ago and was shown to be non-inferior to Warfarin, but was rejected by the FDA because of the toxicity. So embedded in all the protocols subsequent to that time was rigorous liver monitoring. This first slide shows that the Dabigatran is not toxic to the liver. The second slide, next slide, shows Apixaban is not toxic to the liver. And the third slide shows that Warfarin similarly is not toxic to the liver. The next slide details the early development of the Dabigatran. And in phase 2, an extensive dose evaluation was conducted, and you can see by the circled numbers that the 115 milligram BID dose was considered the optimal dose in phase 2, and the dose of 110 milligrams BID was tested as an insurance dose in the event that the bleeding rates of the 150 were higher than anticipated. Next slide. The Reliance trial was conducted by Stuart Connolly, Lars Valentine, including Yusuf and myself, and involved, the next slide, the evaluation of 2 doses of the Dabigatran, 110 and 150, against Warfarin. It was a non-inferiority trial. That was the primary objective. And it was also an unblinded trial with respect to the Warfarin-Dabigatran comparison. As with all these phase 3 trials, stroke was the major endpoint, systemic embolization, and the major safety endpoint was major bleeding. The trial that has been published in the New England Journal with respect to Apixaban was a direct double-blind comparison with aspirin. 5 milligrams BID of Apixaban was evaluated against aspirin. And in the ROCKET trial, Apixaban was compared in a double-blind study against Warfarin. The ROCKET trial was recently published in the past 2 weeks in the New England Journal, and basically showed non-inferiority to Warfarin in that study. Now, the patient characteristics of the Reliance trial are shown in the next slide, and basically these patients had characteristics that I will show you are similar to the patients involved in Aproved, with a mean CHAS score of about 2.1 or 2.2, and also similar to the CHAS score in ARISTOTLE, which was the evaluation of Apixaban. However, the CHAS score in the ROCKET trial was 3.49, so that was a much higher patient population than was evaluated in any of the other trials thus far. This shows, next slide, is the baseline characteristics of Aproved, which is similar to Reliance, and these are the baseline characteristics of ROCKET, which demonstrates a much higher patient population, higher risk patient population that was when it was studied in Rely or Aproved or Aristotle. One of the major challenges in all these trials, in the next slide, is to keep the patients on their assigned medication. And this is true of all the trials currently, that about 20 to 23% of patients are permanently withdrawn from their assigned medication. This slide shows data from the Reliance trial. The next slide shows data from the Aproved trial, where the discontinuation rate was approximately the same as Reliance. And the next slide shows the discontinuation rate in the ROCKET trial, which was about 22 to 23%. So one of the major challenges when these drugs are translated into patient care is to events that I need to discuss with you. The first is dyspepsia. About 2% of patients assigned to Dabigatran withdraw from Dabigatran because of dyspeptic symptoms. The second are GI bleeding. And GI bleeding, particularly for the 150 dose, is higher than what we see with Warfarin. The comparison on average is, this is major GI bleed, 1.6% per year for 150 of Dabigatran, and about 1.1% for patients of Warfarin. We don't understand the mechanism for the increase in GI bleeding with Dabigatran, and this is under active evaluation currently. Next slide, please. In the RELY trial, the time in therapeutic range in the Warfarin group was 64%. That's the mean number, and that was well within the range that was considered optimal by the FDA. In the Rocket trial, the time in therapeutic range was about 55% mean, 57% you can see highlighted the median. This is lower than seen in the other trial and is thought to be a limitation of the Rocket trial, that the time in therapeutic range is lower than seen with the other completed trials. However, the patient population in Rocket is different to all the other published trials, and that may partially explain this low time in therapeutic range. Now, getting back to the RELY trial, the overall results are shown in the next slide for both Warfarin experienced and Warfarin naive patients. You can see for the 110 dose, there is clear-cut non-inferiority, whether the patients are experienced or naive. And for the 150 dose, there's in fact a 35% reduction in stroke and systemic embolization in both experienced and naive patients. This was a surprise. It certainly exceeded expectations and is highly statistically significant. Next slide, please. Now, I'd like to spend a moment talking about risk stratification and the benefit of Dabigatran by risk. So, next slide. In terms of the primary endpoint of stroke and systemic embolization, you can see here that the 150 dose, when compared to Warfarin, is statistically beneficial irrespective of the CHAD score, as you can see on this slide. The 110 dose is non-inferior, also irrespective of the CHAD score. As far as Apixaban was highly statistically significantly superior to Aspirin. That was not a surprise because all studies so far where an anticoagulant is compared to an antiplatelet agent shows benefits of the effect of anticoagulant, and this associated with more bleeding and we check for increases in numerical number. And most of the bleeding difference between the 150 and Warfarin and the 150 and the 110 is due to GI bleeding because, as I will show you in a subsequent slide, intracranial bleeding is massively reduced in a highly consistent fashion in patients assigned to the Dabigatran, irrespective of the CHAD score. Getting back to Apixaban, major bleeding with Apixaban was 14% higher than the disaster, but of course this was offset by the massive benefit in the reduction of systemic of stroke in the Aproved trial. Now, getting back to intracranial hemorrhage, because this is one of the most important features of the Dabigatran, is that there was a very substantial, as this slide shows, reduction in intracranial hemorrhage afforded by the Dabigatran 150 and 110 over Warfarin. This was highly reproducible, both in naive and experienced patients and by CHAD score. And this is an important observation, and we're not sure what the mechanism is, but it's clinically very important. Now, this next slide shows intracranial bleeding by CHAD score, and once again you can see for both the 150 and the 110 dose, there is a very substantial reduction in intracranial hemorrhage reported by the Dabigatran across all this profile. Getting back to Dabigatran in the ROCKET trial, focusing on major bleeding, this trial, as I explained earlier, showed non-inferiority to Warfarin and a 4% non-statistically significant increase in major bleeding. Also, the next slide, focusing on the ROCKET trial and Dabigatran, you can see in the second grouping of outcomes, intracranial hemorrhage was 33% lower in patients assigned to Dabigatran, which is about half the reduction seen with the Dabigatran, but nonetheless follows the fact that the novel agents seem to have lower intracranial, intracerebral, subdural, and subarachnoid hemorrhages than seen with Warfarin. Next slide is the only one of the novel agents to be evaluated in the setting of cardioversion. Next slide is the Dabigatran, and this study was published in Circulation earlier this year. Randy Nagarakamsi was the first author, and basically the third bullet point from the bottom showed that stroke and systemic embolization was reduced in patients assigned to 150. The event rates were 150 BID of the Dabigatran. The event rates were lower, but not statistically so, because the number of events were quite few. But the transmission of the results of this trial is that in patients who've been anticoagulated for greater than 3 weeks, it is safe to cardioverse patients on the Dabigatran, provided you know that they've been taking their medication, and it's a question called whether a TED is necessary in the setting. We usually cardioverse patients after they had a negative TED. So next slide, the conclusion regarding the novelty is that the Dabigatran is the only approved novel anticoagulant. Its characteristics relate to its improved efficacy for the 150 efficacy dose and safety, and a significant reduction in stroke, both thrombotic stroke as well as intracranial bleed, but there is an increase in GI bleed, approximately 6 major GI bleeds per 1,000 patients treated per year. That is the estimate. The other novel agents are in development but are not approved. Rivaroxaban has been shown to be non-inferior to Warfarin. This data has just been published in the New England Journal. Apixaban is superior over aspirin, also recently published in the New England Journal. And Apixaban was compared to Warfarin in the ARISTOTLE trial. The results of this trial will be published tomorrow in Paris at the ESC meeting, and there will be a concomitant publication in the New England Journal, which will also come out tomorrow. But what is public is that this trial is positive, but the details are not available, and the information that I just provided you has come from a press release from about 6 weeks ago. And the next slide is the study design of the ARISTOTLE trial, which will be presented tomorrow. It's a Apixaban 5 milligrams BID against Warfarin in a double-blind trial, and the results will be available tomorrow, as I pointed out. Now, in the future, the Engage-AF trial is currently slated for completion towards the end of 2012, and it involves a novel factor Xa inhibitor Indoxaban, which will be evaluated in 2 doses. Next slide. The primary endpoint will be stroke and systemic embolization. Again, this is the non-inferiority trial. Next slide. And the final slide is also